If you are a BCBA looking to elevate your practice and incorporate strategies that are neurodiversity affirming, compassionate, and trauma informed, this next presentation is for you. My name is Carrie Susa Woodward, and I'm a Board Certified Behavior Analyst that has been practicing in the field for 22 years now. We are going to be diving into the journal article titled Toward Trauma-Informed Applications of Behavior Analysis. And I named this presentation, It Ends With Us, as a bit of tongue-in-cheek, but it has a really deep meaning. Obviously, to anybody who pays attention to anything pop culture related, we've recently had a movie come out called It Ends With Us, and it's based on a book by Colleen Hoover of the same title. And essentially, it's a story about cycle breaking. And in the movie and book, it is breaking the generational cycle of domestic abuse. But for us behavior analysts, I firmly believe that we also are products of what has been passed down to us from the people that mentored us through our graduate school or through our practices. And at some point, we may need to take a look at what we are doing and decide if we are ready to break the cycle of things that we have done without really questioning whether or not they're the right way to go about doing it anymore. So just as an illustration, I wanted to show you a little bit about my behavior analyst family tree. Like I said, I have been in the field of ABA for 22 years, and 14 of those years, I have been a board certified behavior analyst. And for a large part of my practice, I was the product of the behavior analyst that had shaped me and taught me and given me all of the knowledge that I had. So my first BCBA dad is a PhD doctor that worked at the agency that I started working at in 2005. And he was really the first behavior analyst that helped open my eyes to this science. I had worked at 2 agencies before coming to this one. Though I highly respect the people that I worked with there, nobody really ever explained behavior analysis in the scientific terms. We were given strategies that we were supposed to incorporate into our therapy with autistic children. We were taught what we were supposed to be doing, but we were never really taught why or the science behind it. And my BCBA dad number 1 was the first person to ever really start explaining the science. And it was like the light bulb started going off for me. He is brilliant. He is a radical behaviorist, and he is super hardcore. And he is the one that encouraged me to go back to school and get my master's degree to become a behavior analyst. And thus he introduced me to my BCBA dad number 2, who was my graduate advisor all the way through my master's degree. And my BCBA dad number 2 is also brilliant. He is also a radical behaviorist, and he is also very hardcore. And it just so happens that both of my BCBA dads, the people that had the biggest impact on who I became as a behavior analyst, both studied at Western Michigan University under the direction of Jack Michael. So he was really like my BCBA grandfather, even though I never worked with him or met him directly. Because what Jack Michael passed down then got passed down to me, and we had a certain way of thinking about behavior analysis and the way that we applied this science to work with our clients. And it's not to say that my BCBA dads are wrong, but at a certain point, I started to question some of these long-held assumptions about the applications of our science. And so here's me at the bottom of my family tree, where I consider myself to be a cycle breaker. I consider myself to be a teacher. At the agency that I was at for 17 years, I worked with a lot of BCBAs. I managed at least 20 BCBAs by the end of my time there. I like to think that I was a thinker. I made them think and question the things that we had been doing just because that's the way that they were always done. I like to think that I'm compassion forward. In 2018, I had my first child, and I feel like the experience of becoming a mother radically changed the way that I looked at the treatment that we were providing to our clients. Things that I may have looked down on parents for doing, or may have been frustrated by when they questioned what we were doing with their kids, I now completely understand from a different perspective. And I also think that I am still a radical behaviorist. And I believe strongly that there is a place where these two things can be married together, that we can be strong in our science while also beginning to lead with compassion, understand neurodiversity more, and also incorporate trauma-informed care into our practice. And now we have a bunch of research to support things like assent-based practice, neurodiversity affirming practice, and trauma-informed practice. And so my call to you is, with this research in hand, you begin to be the cycle breakers in your communities, in your agencies, and in your schools. I ask you to start questioning some of the long-held assumptions that maybe were passed down to you from the people that mentored you, especially if they don't fall in line with these practices. So we're going to talk about the word trauma, because this is a word that has begun being thrown around a lot more in the last 20 years than it ever was previously. It's actually undergone something we call concept creep. So this is pretty interesting, but at the same time that I was reading through this article, I was also simultaneously reading a book called The Coddling of the American Mind. And he goes through a whole chapter discussing trauma, the idea of trauma, the concept of trauma, the word, and how we use it in our society. And he's the one that discussed this as having undergone something called concept creep, which simply means it has changed and adapted to include a lot more than its original definition. And in the article, Toward a Trauma-Informed Approach to Behavior Analysis, they actually provide 3 separate definitions of trauma. But this one by the American Psychological Association is actually closest to how it was originally defined when it first began to be talked about. So the American Psychological Association defines trauma as an emotional response to a terrible event like an accident, a rape, or a natural disaster. It doesn't leave a lot of wiggle room for how we typically refer to people who have undergone trauma. And in the book, The Coddling of the American Mind, the author's conclusion is that this concept creep has actually led to a population of people that have an increased sense of vulnerability, a heightened perception of threats or harms, meaning people are afraid when they don't need to be. And he might be right when it comes to neurotypical populations. However, because most of us BCBAs are not autistic, we don't have the experience of living in an autistic body. We don't know how lights look to autistic people. We don't know how the sounds are perceived by their ears. And so this concept creep of the word trauma, I think, has actually done us a good service when we talk about the autistic population, because I think it's allowing us to expand this idea of trauma and able to encompass maybe some of the everyday things that autistic people experience that we neurotypicals would not consider traumatic, but which may very well be for our autistic clients. I'm going to reference Dr. Greg Hanley quite a bit throughout this presentation. Not only is he one of the authors of the article that we're talking about, but he's actually one of the beginning pioneers of this idea of a compassionate ABA. And I heard him interviewed on a podcast, and he said this quote, which I think sums up what we're talking about so beautifully. He says, "You just assume that if a child is engaging in extraordinary behavior to an ordinary ask, that there is a history of trauma there." And this really could be our thesis for the whole article and what we're going to talk about today. And I know that as a behavior analyst, sometimes this concept of an assumption can feel uncomfortable. And we're going to talk about how the article outlines why we have been so behind in adopting trauma-informed care practices. Because we are so concrete, we are so tangible, we are so data-driven, that a lot of the discussion around trauma-informed care can get a little uncomfortable for us. But I encourage you, let's get uncomfortable. So this idea of trauma-informed care is not unique and it is not new, but it is pretty new to ABA. And what is it? The authors of this article define trauma-informed care as knowing the history of past and current abuse in the life of the consumer with whom one is working, and using that understanding to design service systems that accommodate the vulnerabilities of trauma survivors and allow services to be delivered in a way that will facilitate consumer participation. Now, facilitating consumer participation should not be a novel thing to behavior analysts. This is Assent. It's now widely discussed as part of our ethical codes. We all need to be a lot more aware of our clients' willingness to participate in the therapeutic process. And the article even suggests that this becomes necessary, that the client is an active, willing participant to the process. And without it, therapy cannot succeed. And I'm going to radically expand on this idea of Assent as we go through this presentation. But first, the authors discuss the barriers. Why has ABA been so late to the game? Why have we been so unwilling to adopt a trauma-informed approach to our practice? And they identify 3 specific barriers. The first is conceptual confusion. Because let's face it, when we have to acknowledge the past trauma or abuse of our clients, this may not be something that we've directly observed. Though the sources of trauma are most likely extrinsic, meaning that they are in our observable world, which behavior analysts love, The psychological trauma that exists as a result of the trauma is not observable, and we do not like things that are not observable. When we talk about private events or the things that are going on the inside of a body, we acknowledge their presence. We include them as possible stimuli that are impacting behavior, but we aren't able to measure them. We aren't able to observe them. And so though we may discuss them, they do not become a focal point of any treatment plan. The second barrier that's identified by the authors is the conceptualization of the causes. When we discuss trauma, this is going to be always something that's happened in the past. These are contingencies that we did not directly observe. And for a lot of autistic people who have deficits in their communication skills, they may not even be able to accurately verbally report their traumatic experience. But should this make us ignore the idea of trauma because we didn't observe it and we don't have clients that can tell us about the event? I think that does our clients a disservice. And then the third barrier to discussion is this lack of evidence. We are still so new in incorporating trauma-informed care practices into ABA that we don't have a lot of empirical research on their outcomes and best practices. But I think for all of these barriers, if we can strip away the complexities and remember the population of people that most of us are supporting, I believe that our ethical obligation is to protect our clients, and that obligation is greater than us getting hung up on the minutia. And I will say this, as practitioners, I have yet to read any research that shows that incorporating neurodiversity affirming practices or trauma-informed care leads to negative outcomes for clients. And so if these are not going to harm our clients and could potentially protect them from additional trauma, why wouldn't we start incorporating them? And so here we're going to go through the proposed framework for incorporating trauma-informed care into your ABA practice. These are actionable, tangible strategies that will be relatively easy for you to begin evolving into your practice and sharing with the practitioners with whom you work and using this research to start questioning some of the practices that have been around and been passed down generationally from the people that mentored you. So the authors outline 4 components to this framework of incorporation of trauma-informed care. And the first one's pretty easy. Let's acknowledge the trauma, assume trauma, and program for its potential impact. Now, this doesn't mean assume every single client you've had has had some sort of traumatic event in their life. It is not an assumption for everybody, but it is an assumption when we see behavior that might be indicative of a history of trauma. And this sort of goes back to Dr. Hanley's trauma assumed care. When we see a child have pretty extraordinary behavior over something relatively simple, then we can assume that the history of trauma is there, and we can move forward accordingly with that client, do best protect them. And an assumption can be done in a pretty safe way because the authors lay out all of these risk factors of trauma, meaning if you have people who are in any of these groups, they may have a higher chance of a history of trauma. And the people that we serve fall into a lot of these risk categories. These are things like being children. Children are at a higher risk or an elevated risk of trauma. Why? Because they're young and they're vulnerable and they may not have the skills yet to protect themselves. And if they are alone or with others that may take advantage of them, they're at a higher risk of falling prey. People with intellectual and developmental disabilities are also at an elevated risk for trauma. And people that have communication as a core deficit are also at an increased risk of trauma. They can't report what's happened. Just because we don't know of the traumatic event doesn't mean that there wasn't a traumatic event for this person. So when they engage in severe behavior, that should be our clue that there is a history of trauma with whatever it is that we are doing in that moment, with the environment, with the setting, with the stimuli that are being used, with the instruction that's being given. And so what do we do once we have acknowledged and assume the trauma? Well, the second piece of the framework is to ensure safety and trust. And the authors refer to 2 ways that we can ensure safety and trust. One is this concept of safety signals, and the other is this idea that our kids should be approaching the practitioner. So what's a safety signal? Essentially, they are stimuli that predict periods devoid of aversive stimuli. So these are things in the environment that are often present When a child is not being presented with aversive tasks, not being asked to engage in aversive activities, and there are no aversive things around for them. I think just from a human perspective, you can see how we all have safety signals. We all have things in an environment that cues us to feel safe. And when we feel safe, we are more willing to be in that environment and to participate in whatever activity is happening there. And so the authors suggest that it is our job to create environments that are replete with safety signals, allowing your client every opportunity in the world to willingly come in and participate in therapy in this environment. When we have environments that are missing safety signals, you are going to see escape behavior before the client even walks into the room, even comes into the class. And this is going to set your kid into heightened state and maybe some severe behavior. And then what do? So instead of pushing our kids by ignoring this recommendation, instead we create environments that are replete with safety signals. How do we create safety signals? Well, pairing, right? We take stimuli that may be neutral at the beginning, and we pair those with non-aversive things, with highly preferred activities, highly preferred tasks, highly preferred toys, highly preferred people. And it is through this continuous pairing that we can condition these safety signals. And this is how we create safety for our clients. The authors then talk about this concept of trust. And essentially, they define trust as a reliable interaction in which a client independently approaches the practitioner and readily communicates for reinforcers across contexts due to a reinforcement history with that practitioner. And I think, again, we can sort of go back to this idea of assent, which is already pretty standard in an ABA practice. What is assent? It's when a learner, verbally or non-verbally, agrees to participate in therapy. Or if approaching the practitioner is essentially trust, and then we would say that escape or avoiding the practitioner is a lack of trust, aren't we better off just talking about it as removal of assent? Because that we know what to do with. Anytime that there is removal of assent, we need to pause and reconsider what we are doing in that moment with that client. And I think that this idea is going to challenge you to pretty radically question some of your assumptions about escape behavior. There's this amazing presentation that Dr. Jonathan Tarbox has done, and it's on Behavior Live. I will link it at the end of this presentation, and it's free 2 hours of Ethics CEUs, and I think it should be required watching for every behavior analyst that is practicing with an autistic population. The presentation is called Assent is as Behavioral as B.F. Skinner. So we're going to talk a little bit about some of the things that he discusses, because I don't know that we can really talk about trauma-informed care without really bringing in this idea of assent or assent withdrawal. Dr. Tarbox's philosophy is pretty radical, but it's not radical because it's something that we can't do or that we shouldn't do. It's radical because almost nobody is doing it. But he essentially says any escape behavior at all from your client should be considered removal of assent and should justify us stopping. Now, that doesn't seem right? Like all that we have ever learned in a grad program and what's been passed down from us in our practicum practice is that when we have maladaptive behavior, we identify the source of reinforcement, we conduct a functional analysis or an FBA, we identify the maintaining reinforcers, and then we withhold access to those reinforcers when maladaptive behavior occurs. This is called extinction, right? This is one of our main tools within our toolbox to address problematic behavior. If we're not going to punish problem behavior, because we know that there are a ton of negative side effects of punishment, and it's just unethical unless we are at a critical and dire place for a child's behavior. If we're not going to use punishment, we have to utilize extinction to get maladaptive behavior to go away, right? So if we have to consider that every escape behavior is considered withdrawal of assent, and that withdrawal of assent means that this person is no longer a willing participant in therapy, that means that we pull back and stop. That means that escape extinction doesn't happen. That means that we don't continue to prompt a child. We don't push through these periods of discomfort for the child, that we don't continue to facilitate the activity until the child complies. I want to just pause and take a moment, and I want you to think to yourself, could I be a practitioner that does not utilize escape extinction in practice? Can we be effective behavior analysts without escape extinction? But the beauty is that we fall back on the science. And when we have research that shows us that we can be effective in reducing maladaptive behavior without the use of escape extinction, I think that we need to really consider it. I believe that practitioners have been unwilling to adopt this for a couple of reasons. One, because when we have strategies and practices passed down to us from people that we admire and trust, why question it, especially when it's effective? How can we get anything done when our autistic clients push back on instructions or engage in escape behavior if we just allow escape to happen? How could we ever get anything accomplished? But when we think about the humanity of the clients that we are serving, when we think that maybe it will take a longer time, maybe progress will be slower, but it will have been done in a more compassionate approach that didn't push children or adults into these heightened emotional states that are wildly uncomfortable for them and everybody else around, that we could do it in a slower and more gradual way and still make progress, I think that we need to explore that possibility. In the article, they have a whole section that talks about this idea of restraint. Now, I worked at an agency for a very long time, made up of really, really good behavior analysts, great scientists and practitioners. And because of this, we were really, really effective at our jobs. And that meant that our agency was often the one that was called when school districts had clients that had sort of reached a point where they could not be helped anymore. Less effective ABA agencies had tried and failed, the school district had tried and failed, and we had kids that were engaging in incredibly severe problem behavior that was damaging to themselves, damaging to people in the classroom, high levels of aggression, high levels of outbursts. And so in the course of our work with these kids, there were times that we did have to utilize restraint procedures in order to keep these kids safe from themselves and keep everybody else in the environment safe. And I think that we can all agree that at the point where restraint even needs to be considered, the behavior is most likely so severe that we now have to assume that there is most likely a history of trauma related to whatever it is that evoked that high magnitude problematic behavior. And if you've been practicing for a while, I think that you can acknowledge that we almost never see high magnitude severe behavior right away. We most likely see precursor behaviors, low magnitude behaviors that are the beginnings of behavioral escalation, and that because of what our practices are, we typically push through that escalation. We see low level, low magnitude escape behavior, and we think, can't allow escape to happen or else we're going to end up reinforcing that problem behavior. And it's going to get worse. We think in the long term. We think of behavior over time. I can't reinforce this instance of behavior because I don't want this behavior to increase over time. But what if we take a smaller temporal view of the behavior and say, I am not going to push through this low-level behavior at the risk of reinforcing it because I do not want to push our client into a higher magnitude, more severe episode of behavior for their own sake and for our own sake. And so a trauma-informed approach would then say, reinforce low magnitude, early signs of problem behavior before escalation. Provide escape when that low-level behavior happens so that you never ever push a kid into a place where restraint even needs to be considered. For so many reasons, but one of the main things that the authors were talking about is that we have our practitioners, our technicians, implementing these restraint procedures. And we have to probably assume that this restraint procedure is an aversive procedure. Now, are there very random instances where restraint may be a reinforcer for a specific client? Absolutely. But for the most part, I think we can say restraint most likely functions as some aversive event for the person who's having to be restrained. So if we have a technician who works directly with a client implementing restraint, how is that technician ever going to become a safety signal? They are now paired aversive. So now we are sort of snowballing this problem of the ensuring of trust and safety, because once we have to push our child into this escalated state and implement restraint procedures, the technicians that have participated in that restraint no longer function as safety signals. And so we're going to start seeing escape behavior even before the client walks through the door to participate in therapy, which means we're going to have a harder time getting our kids assent into the therapeutic process. So though you may think that it is more effective to implement escape extinction to address that one behavior, when you look at it from a more global perspective, we're really doing harm to the process of getting the kids' buy-in into therapy, and that's impacting negatively their whole program. All right, so the third piece of the framework for incorporating trauma-informed care into the ABA practice is promoting choice and shared governance. And essentially, this means client control, choice, and autonomy. When we talk about choice, I think this is probably one of the easiest assumptions, that most practitioners are incorporating choice. We have lots of research on the benefits of choice and how important choice is to a successful program, and not just choose which reinforcer you want to work for. Preference assessments, right? That shouldn't be the only level of choice in a child's program. But how about choose what task you'd like to do, in what order? Choose the stimuli that you'd like to work with or play with or manipulate. Choose the setting that you'd like to work in. We have to incorporate a high level of flexibility with what our ideas are for a session in order to allow the highest level of choice for our clients. Choice increases their buy-in. It increases their participation. It increases their willingness to participate, their assent in the program. Also, in the context of Dr. Tarbox's presentation on assent, he talks a little bit about coercive control. And there's a chapter in a book from 1979 where the author, Brigham, defines choice as uncoerced selection. And that means that there is no differential outcome for whichever choice is made. And I think we really need to continuously come back to this idea as we are deciding what choices we're going to be offering to our clients in the context of a session. Are our choices truly uncoerced? But this idea of governance, I think, is a bit more novel to behavior analysts, and it's probably something that we are not incorporating into our ABA programs. Governance means everyone that is involved in the program gets to have a voice, and this includes the client. And I think that practitioners and parents have avoided governance because that makes our jobs more difficult. As a practitioner, I can't be as effective if I am really giving a loud voice to my client. And that says something about the type of therapy that we are providing. As a parent, if I am only concerned with the outcome of therapy, of the progress being made, I don't want my child to have much of a voice in the process because I want the process to be the most effective. And if my child's voice is going to derail the effectiveness of the process, I'd like to avoid that. And so what do we want to offer our clients in terms of governance? Well, they should have a voice in the type of treatment that they are receiving, the types of programs. Is it more discrete trial-based? Is it more naturalistic and play-based? The goals. What types of skills are important to the client to learn how to do? How we define mastery. What skill level must the client achieve in order to be considered successful? And the difference from the way that we have typically done things is that usually practitioners have some element of social validity at the end of treatment, right? So like in research, you'll often read in the discussion that there were social validity measures that were provided to the parents at the end of the treatment, for the parents to be able to provide their opinion about the treatment and the outcomes of the treatment. I think social validity is still a really good measure, and we underutilize social validity with clients themselves. But this idea of governance actually sets out that it is all done before treatment begins, that we as a group, including the client, are discussing things like the type of treatment, the goals, the mastery, before we begin treatment. In this article, they discuss a bit of Dr. Hanley's work. He's done a lot of research on concurrent chains, meaning that there are two different schedules of reinforcement or strategies that a child is exposed to, and then that they are allowed to choose which one they like better for the remainder of treatment. And this is like an amazing measure of governance and autonomy and choice, that the client is actually getting to choose the type of treatment that they're participating in. And obviously, this is gold standard. I think it's a bit difficult to apply in a realistic way as a part of every client's ABA program. But I do think it's something that we need to consider. How can we be building in uncoerced choice in more than just presenting 2 items to our child to select? And coming again back to this idea of assent, we also need to consider that removal of assent is a choice. And it has to be a choice that we allow a client to make. And removal of assent does not necessarily mean that you have to stop and do nothing. This would be a really hard sell to parents and funders. We're going to pay you to walk into the house and have a client tell you they don't want to participate in therapy today, and you're just going to sit there and do nothing? Or you're going to cancel and have the hours go unused? No, removal of assent does not need to mean stop and do nothing. What it needs to mean is stop and do something else. Do something differently. Approach that task or program or ask in a different way, in a gradual way. A past version of me would have also considered throwing out, we just need better reinforcers for the client. Let's talk about a toothbrushing task, right? We have a kid who needs to learn how to brush their teeth. But we are also being met with pretty significant escape behavior at the presentation of the toothbrush. When we talk about removal of assent or escape signaling the removal of assent, there are certain things that we have to do for safety purposes, for health purposes. This client is going to need to know how to brush their teeth. They're going to need to at least allow somebody else to brush their teeth. Better to learn how to brush their teeth themselves. And if we're going to consider removal of assent, when that escape behavior happens, how do we get to the end result of teaching teeth brushing while also honoring the removal of assent and not pushing our kids into an escalated emotional state? Well, I would have said, we just need to identify the most highly preferred thing for that client. Ooh, these cookies are his favorite. Now, mom and dad, never ever give him these cookies outside of therapy. These cookies are going to be reserved only for toothbrushing. Okay? We know the power of reinforcement. We know how to make reinforcers more powerful and effective. Deprivation is sure one of them. So we're going to deprive, and we're going to establish a much stronger EO for these cookies. And then maybe we're going to get compliance with the toothbrushing task. But if we will go along with Dr. Tarbox's argument that true assent has to be uncoerced, this doesn't really work, does it? This means that it's still not assent if your client willingly participates in therapy, but only because they are hoping to avoid an aversive situation. And being without their favorite cookies for long periods of time is aversive. And so to avoid that continued state, they're going to comply with the task and participate. We would consider that coerced assent. So today's me would do it differently. Today's me would pull way back. Get out of the bathroom. If the bathroom does not have safety signals, we have to do a lot to establish and condition safety signals in that environment before we even go back into that environment. Reinforce for simply walking across the bathroom threshold. Take the toothbrush out of the bathroom and do things with it that are fun. Play baby doll and brush the baby doll's teeth. Brush the dog's teeth. Watch some videos that you find on YouTube that are funny and all about toothbrushing. Find that Elmo song and brush, brush, brush it, brush, brush it, brush it. If they laugh and they're enjoying it, we are doing the proper conditioning in order to start establishing safety signals with the stimuli being used. We then can move into the bathroom and do these things. Brush the baby doll's teeth at the sink. Watch the video on the iPad in the bathroom. We build gradually. We mark success at much lower levels than by simply saying success is when you get in and finish the whole toothbrushing routine. Old me would have pre-made a task analysis of all of the different steps of the toothbrushing chain that we are going to use. I would have interviewed the parents to see their process for toothbrushing, and I would have outlined it in the exact same way. New me would say, at the moment that we get escape behavior or withdrawal of assent, that's where we stop and we reimagine the rest of the task analysis. We do it smaller. We have it be a dance. We move forward, we move back when we have a problem. We move forward in a smaller way. We move forward to a side. We do it differently. We explore options. We don't have a pre-made list, but we have an evolving and changing list that we reevaluate every single time that we work on this skill. Is it slower? Probably. Does it get to the end result? Yes. And have you gotten to the end result without pushing your child into a heightened emotional place where they are distressed and screaming and engaging in problem behavior that is most likely going to require some restraint if it gets severe enough? Yeah. So slower is better. And that's what we need to sort of retrain our brains to think about when we are writing goals for kids, when we are imagining how this program is going to look for a client, that it might be a slower process to get to that end result. And lastly, we also need to consider that a client has the right to choose no treatment at all, at least for today. There's a brilliant article that gets referenced in this article that deserves its own read if you have not read it yet. The article is called Balancing the Right to Habilitation with the Right to Personal Liberties, the Rights of People with Developmental Disabilities to Eat Too Many Donuts and Take a Nap by Bannerman et al. In 1979. Highly encourage you to look it up and read the whole thing because there are so many gems. But essentially, this quote from the end of the article is one of the most important things that we need to consider with allowing our clients this choice of no treatment. All people have the right to eat too many donuts and take a nap. But along with rights comes responsibilities. Teaching clients to exercise their freedoms responsibly should be an integral part of the habilitation process. And what they're essentially saying is that making choices is a skill. We could all make choices based on motivation and preference alone. Everybody from birth is essentially making choices, what they look at, what they're going to put their eye gaze on, what their attention is going to be focused on, what they're going to reach out and grab, right? But making choices that are in our own best interests can be considered a skill, and that if your clients do not have this skill, that has to sort of be taught at the beginning before choice can really be allowed in the way that it needs to be allowed for the client's autonomy and governance in the program. If we allow choice because we've been told that we have to, that it has to be a part of the program, but our clients have not learned how to make choices responsibly, then you might have a client that chooses to eat donuts and take a nap every day. And this article is not just about telling practitioners that they need to allow clients the opportunity to eat a donut and take a nap. It is that we need to be responsible to help this balance, that clients also have the right to habilitation, to making progress and gaining skills that are going to set them up for success. And it's not just developmental disabilities. It's not just kids with autism. I think for any kid of a given age, when given the choices where motivation is the ultimate control, they're always going to make the choice that serves their motivational interests and not the one that is in their best interest long term. when given the choice to eat a donut or broccoli, and it's uncoerced, meaning there's no differential outcome on whichever choice they make, they're gonna choose donuts because they are driven by their motivation and not by their understanding that if I delay my own gratification today in this moment with the donut, I'm going to benefit from it down the line because I'm eating more healthily. My job as a parent for my 4 and 6-year-old is to help make that choice while also teaching them about the long-term consequences so that they can begin to make better choices for themselves. And that's our responsibility as practitioners with our clients. We do need to incorporate choice, but we cannot incorporate choice only if we have not done the work to help teach the skill of responsible choice making. And so this should be at the beginning of your treatment plans for your kids. After assessment, there's so much that needs to be done before you jump into learning how to follow instructions or sit at a table or keep your hands still or whatever your normal first goals are for your clients upon assessment. There needs to be a real reconsidering of the most important skills that need to be taught before you jump into those other goals. Okay, and so the fourth element of the framework of incorporating trauma-informed care into our ABA practice is emphasizing skill building. This seems relatively straightforward, right? We're behavior analysts. All we do all of the time is teach new skills. That's our job. Easy, we got this. But it's not just straight up skill building, right? What they are talking about in this article is that we are focused on teaching alternatives to problematic and maladaptive behavior, the behavior that comes as a result of this history of trauma, so that we can compassionately address problem behavior that is most likely interfering with their life and their learning and their ability to be successful without needing to subject them to the traumatic experiences that will evoke that problem behavior. So some of the procedures that we may have used in the past to decrease maladaptive behavior, like escape extinction, we now have to not consider that, right? Okay, well, let's work on a DRO. Let's do differential reinforcement of other behavior. This is successful in decreasing the problem behavior, but it does nothing to teach a better alternative. And so the focus should really be on DRA procedures. So if you've been a behavior analyst for long enough, you've obviously been exposed to Dr. Hanley's ISCA, the Interview-Informed Synthesized Contingency Analysis. If you haven't, I encourage you to read about it because I don't think that there's a right or a wrong way to do a functional behavioral assessment. I think that there are lots of practical applications for a traditional FBA approach or a traditional functional analysis that looks to expose kids to contingencies to be able to determine with a high degree of certainty what the maintaining reinforcers are, what the function of the behavior is. But the ISCA is this really beautiful alternative that we also need to consider, especially when the behavior that we are looking at is so significant that it's dangerous for us to put a child into a situation where we are intentionally trying to evoke the behavior. And sure, we may not push kids into escalation. We reinforce the behavior immediately in a functional analysis, so it should terminate the behavior at a low level. But Dr. Hanley argues if we don't need to do that to still have a successful outcome on determining function of behavior and addressing maladaptive behavior, why would we do that? It's unnecessary and unkind in some situations. So I got the opportunity to listen to Dr. Hanley give a presentation at a conference 8 years ago. And it was this really cool one-day conference in Santa Ynez, California, in wine country. And it was the first time that this idea of a more compassionate approach to ABA was introduced. And it was the beginning of my questioning of all of the things that I had learned and assumed, all of the strategies that we employed on a regular basis, because that's just how you did it. And it was the beginning of my cycle breaking, my rethinking, my questioning. And in this presentation, he discusses this idea of this open-ended questionnaire that you go through with parents. And I loved this analogy. He said, if you asked a parent, when you're doing an assessment of a kid, if you asked the parent what the function of their problem behavior was, the parent would be like, I have no idea. I have no idea. It's mind-boggling. But if you ask the parent, when your child is engaging in this problem behavior, do you know how to turn it off? And the answer is almost always yes. Yeah, give them the candy bar. Yeah, don't make him brush his teeth. Yeah, tell him he doesn't have to go to school. He can stay home and watch video games. It does not give you a solid function, but it does give you a lot of insight about what are the things that may be evoking the behavior and how can we get the behavior to stop in the moment. And so once you have this information, you can work to teach a generalized demand, a generalized request, a single word or phrase that the client can use in order to access the reinforcement that they're looking for. Old me scoffed at this idea of teaching a generalized demand, everything that we knew about verbal behavior. And remember that my BCBA dads studied under Jack Michael, which is like one of the fathers of verbal behavior being disseminated. And this idea of a generalized demand was counterintuitive to being able to expand a child's verbal repertoire. If you just teach the demand more, they're not going to learn the more specific demands for cheese, cookies, crackers, grapes, all of these things that they need practice in order to learn. They don't have to practice because they can just say more and somebody is going to take a guess at what they need. The problem with generalized demands, not only in that it inhibits the learner from acquiring a more robust verbal repertoire, but it doesn't serve the learner when they go out into communities of people who may not have a history with reinforcing that demand for them. More what? Maybe it was something the child had at home and now they're at school and they're just doing this or saying more. And the teacher has no idea what they're asking for. And now we're getting frustration because the child cannot communicate what they want. So old me scoffed at teaching this generalized demand. But you don't teach the generalized demand at the exclusion of working on more specific demands. You teach it for a temporary solution, and then you begin to expand on that. So since it's been 8 years since I saw Dr. Hanley give this presentation, we've obviously incorporated this strategy into a lot of practical work with our clients. And so I'm going to give you just one example of how we were able to utilize this and the difference that it made in the treatment outcomes for this specific client. So we had a client who would engage in problematic behavior when anybody else flipped the light switch. She wanted to be the one that flipped the light switch. It wasn't a repetitive on-off thing. It was just that when the light switch was going to be turned on or turned off, she wanted to be the one that did it. And if another person flipped the light switch on or off, she had to go fix it herself right away. And if she was blocked from doing that, we had escalations of problem behavior. And because what we know about extinction is simply identify the source of reinforcement and then withhold access to that reinforcement so that the behavior can go away. And so what we would do is we block her from accessing the light switch. And this immediately escalated behavior, often to a point of self-injury or aggression toward other people. And we thought we were doing the right thing. We've identified the reinforcer. We understand the function. We're withholding access to the reinforcer to get the behavior to go away. And every time we are working on this, we are pushing her into this heightened level of distress. And the thing that we weren't really considering, the reason that it wasn't getting better, was because we had it on an intermittent schedule of reinforcement. There were times where she walked into a door and nobody else was around and she got to flip the switch on and off. So we were creating a problem that was more resistant to extinction because sometimes she was allowed to flip the switch and sometimes she was not allowed to flip the switch. And so we were not seeing success with utilizing extinction. So following this presentation by Dr. Hanley, we return home from the Santa Ynez conference and I say, okay, we need to try to use this with this client. And we walk in that door and we flip on the light switch. But before she can have any heightened behavior, we immediately prompt her to say, my way. And she says, my way, and we back up and we let her flip the switch herself. So we are reinforcing an alternative, a better alternative. We are teaching a generalized demand, but one that allows her to effectively communicate her needs and wants in that moment. And we are avoiding an escalation of problem behavior because she has access to the reinforcement. And we do this until the demand, my way, is happening consistently, until she meets mastery criteria. And then we begin just sort of delaying the delivery of the reinforcement a little bit. What we're going to do is try to increase the time that she has to sit with whatever discomfort is happening as a result of not accessing the reinforcer, and then reinforce it before problem behavior occurs. And so this looks like walking in, us slipping on the light switch, her saying my way, and us looking busy. Yeah, you can do it. Go ahead, my way. And then we sort of increase this delay. We increase the amount of time that she has to sort of be uncomfortable and not access the reinforcement before we allow her to access and do it her way. Then we start to actually deny reinforcement. Not this time, maybe next time. And then let her do it right away after that. Okay, now it's next time, you can do it, my way. And it was fluid. Like, instead of having a strict criteria of when to move from one stage to the next, it was really more of a shaping procedure. We would push, and then the moment we would see a little bit of distress happening, we would pull back. And we'd push and we'd pull back, but we did this in a way that we were always in a forward momentum. We were always moving toward our terminal goal without ever really pushing her into this really heightened, escalated place. And we accomplished the goal. We were able to decrease significant problem behavior when other people turned on the light switch. We taught communication skills that she then could generalize to use in other places and in other scenarios where she was feeling very uncomfortable about the scenario and she wanted to do it her way. We did not have to utilize extinction. We did not have to push her into escalated periods. We did not have to push into self-injury and aggression. And we severely enhanced her therapeutic time because we weren't having to sit through 45-minute long meltdowns about the light switch where no learning was happening. Instead, we got to capitalize on every moment of the therapeutic process and teach in those moments rather than sitting through and wading through this extinction period. If you're not familiar with the ISCA, I highly encourage you to read about it, read some of the literature from Dr. Hanley. He also has a 10-hour training on how to administer the ISCA. And if you are not incorporating these strategies into your daily practice with your clients, you need to start considering it. Here's my end sentiment to you. We continue to be radical behaviorists. We continue to practice the science, but in a way that is the most compassionate that we possibly can. Compassion as a core tenet of our practice. I challenge you to question previously held assumptions about your practice and how you can be the leader of change in your organization, at your ABA agency, at the school that you work in. How can you be the cycle breaker and begin to introduce some of these concepts to your fellow colleagues? Today, I continue my cycle breaking and teaching by doing this CEU presentation for you and hoping that it can impact the practice of any behavior analyst that happens to come across it. If you are a parent that happened to stumble upon this presentation, you can be the cycle breakers and the instigators of change for your child's ABA program. If you have an ABA program and you have practitioners in your house and you are seeing things like escape extinction or practitioners that are pushing your child into these heightened emotional escalations, I encourage you to share this presentation with your BCBA and practitioners. Tell them about trauma-informed care. Encourage them to do some research. Give them this list of resources of different articles that they can be looking at and consuming to shift and adopt a trauma-informed care approach into their ABA practice. Thank you for joining us at Autism Jumpstart and CEU Learning Lab, and I look forward to sharing more about behavior analysis as we go on.